I do want to thank Aurora University, even though no one from Aurora University actually ended up coming today. They graciously let us use their space and use their mannequins. So it's one of those things that I'm very grateful for them doing that. So kind of getting a few little band-aid things off, because the BOC requires it. I have to give some certain disclosures. Pretty much I'm not making any money on this presentation today. I have no financial stake in any product or supplier that I'm going to be discussing today, and I otherwise have no other conflicts of interest as to disclose. Check mark. All right, so moving on with the stuff that the BOC wants me to do, we have to talk about some learning objectives today. So what is the goal of today? Okay, so walking away from today, I want you to be able to recognize and identify the various anatomic structures of the respiratory tract. Understand the physiology and pathophysiology of both ventilation and respiration, because guess what? They're not the same thing, even though we tend to use them interchangeably. I want you to be able to differentiate and be able to select from the different types of airway adjuncts that exist based on how they work, when we should use them and when we shouldn't use them. On that same vein, I want you to be able to tell the difference and be able to choose from the various types of oxygen therapy that we can do based on what they're able to do and when we should and should not use them. And at the very end, basically, I want you to be able to use each of them based on nationally recognized standards. Okay, so the standards we're going to be basing them on is the National Registry of EMTs, as that is the benchmark that all emergency care is based off of, at least throughout most of the country. Starting with the boring stuff, flashbacks, freshman year of college. Oh God, anatomy. All right. So we slice. I turn you on your side. I slice you in half. We're looking at our upper airways. Okay, so pretty much here. Okay, it seems like my laser pointer is not working so well. We start with the nasopharynx. Okay, so this is the orange area. Okay, it's all of our airways superior to the palate. Our oropharynx is the mouth, pretty much, so the mouth to the back of the throat. So pretty much tongue, yellow area, down to about the level of the epiglottis. Okay. Then we get past the into our lower airways. So obviously we have our larynx, the overall structures that hold our vocal cords, our epiglottis. Okay. Once we kind of transition there, we're into the full respiratory tract. We have the trachea. Ultimately, we split into the main stem bronchi. Even smaller down, we get into our bronchioles, ending ultimately at our alveoli. Okay. As we deal with our patients, we're trying to have as much control over various parts of this system as we can. Okay, each airway has a different job within these structures. Okay, so physiology of ventilation. Okay, ventilation is the act of air coming in and out of us. Okay, so we have the pleura, the shrink wrap around our lungs. Okay, it pulls the lungs tight and it creates a negative space in the chest, a vacuum. Okay, so the lungs stay inflated. Okay, keep them expanded. As our diaphragm contracts and our intercostal muscles contract, that makes the chest get even bigger and it creates a billows effect. It opens that chest up, pulls more air in. Overall, eventually air gets down to the alveoli, diffuses through the cell wall into the capillaries. We have our gas exchanges. Okay. Then our diaphragm relaxes, the billows effect drops, and then the air is brought out of the lungs. Okay. Our upper airways, like our nose and our mouth, moisten the air and clean it. Okay, so that's why breathing through our nose is so good, because it helps get all that stuff so you don't go and take a nice big lung full of, Marlboro's Best. Okay. We also have the epiglottis that acts as essentially a gate. It is a security gate that prevents stuff from coming down, so you don't choke to death on food, liquids. You shall not pass. All right. So like I said, there's a difference between ventilation and respiration. Even though in our offices we count respirations, right? Well, this is not technically true. We're counting ventilations because respirations is a cellular process, not a mechanical process. Okay. So oxygen diffuses into the bloodstream from the lungs, okay? Ultimately, then attaches to the hemoglobin molecule and the red blood cell, okay? Only about 98% actually goes on to hemoglobin. About 2% actually dissolves into serum, okay? Just because it's sort of like a little extra. Once we get down to the tissue level, our oxygen diffuses out based on a concentration gradient, okay, because physics. At the same time, carbon dioxide, water, and lactate, in theory, comes out of the cell and into the bloodstream. Unlike oxygen and hemoglobin, carbon dioxide has a completely different relationship with the blood. Okay, it's about 7% goes into the serum, 25 to 30% goes onto the hemoglobin, but the rest of it really goes onto bicarbonate ions and gets moved through that way. Because of this, carbon dioxide has an impact on our blood's pH. And ultimately, our ability and rate of breathing is dictated by our blood's pH. Some people sometimes have this misconception that we breathe because we need oxygen. Yes, we do, but the actual rate that we're breathing is based on the pH of our blood. It's a chemistry thing that we're doing when we're breathing, not a purely metabolic thing. Okay? And then ultimately, as blood comes back to the lungs, carbon dioxide and water will diffuse out of the blood into the villi and then ultimately out into the expired gas. Okay? If you're more of a picture person, everything I just say comes up in this picture. Okay? All right? Because I think, Brian, that's a lot of words, right? Can you just kind of boil it down? Okay? Like I said, this is boiled down. Okay? Oxygen is primarily on hemoglobin. Carbon dioxide is primarily on bicarbonate ions. Things shift and move out as they need to based on concentration gradients. But ultimately, at the end of the day, this is why we are worrying about oxygen therapy and airway adjuncts. It's all about making sure that this process stays intact. Okay? Pathophys, okay, when the car goes off the road, when the train's off the rails. Okay? So what interferes with that process of that nice little diffusions in chemistry and things that, with a lot of syllables that make us cry, as we probably go and think back to X-Phys, right? Airway obstructions. Okay, if I got something that's blocking air going in and out, well, this whole process gets kind of thrown out very rapidly. Okay, but there's basically two varieties of an airway obstruction. There's the anatomical and the mechanical. Okay, anatomical is, okay, you're laying on your back and your tongue slid in the back of your throat and you're snoring. Okay, or you've been stung by a bee and your throat's swelling shut. Okay, yes, there's a mechanical force, but your anatomy is the one that's doing it. As opposed to that hot dog that you didn't quite chew enough. The coins that your small child decided to go and eat. Something that is physically blocking the airway. The overall concept that oxygen carrying capacity has been impacted. Well, gee, Brian, that's got a lot of syllables, a lot of words to it. We look at this from the idea of hypovolemia, okay? You got a leak. You fundamentally do not have all 5 liters of blood in you. You do not have as much blood to carry that oxygen. Okay, so that's going to impact quality of ventilation, that's going to impact the rate of ventilation, that's going to impact respiration. Anemia, okay, if you're overall just missing red blood cells, okay, that's also going to create a problem for carrying oxygen. And then ultimately, something that we still think about and why it still becomes a preventing sudden death concept is sickle cell. Sickle cell, because now that cell isn't shaped the right way, it's not going to carry oxygen the same way, and not nearly as effectively. And then one of the last things that comes into the broader concept of pathophysiology of breathing problems is acidosis. Like I said, the whole carbon dioxide thing comes down to a pH control mechanism. Okay? So if we have increased or abnormal metabolic activity, we've been exercising, we have some sort of diabetic issue going on that's creating additional acid in the body. These are going to create changes in ventilation, create higher demand for respiration and ventilation. And then there's the overall concept of hypoxia. Overall, the tissues are getting deprived of oxygen because of what's, if you go once again back to our anatomy and physiology, the minute volume, how much air we're moving per minute. Okay, if something's impacting that. Okay, I have a collapsed lung. Okay, that lung is now no longer, I'm now not going to move that same amount of volume. Okay, I am having an asthma issue. The airway structures are smaller. The air is more resistance. I am decreasing the amount of air that's getting to the lungs. Okay, or hyperperfusion. Once again, like, okay, you're having a massive heart attack and your heart's not moving stuff well enough now too. Once again, your ventilation systems are working as great as they can, but they can only do so much. Okay, there's what's called the dissociation curve that is used in medicine. So anyone here happen to remember what a normal oxygen saturation is for a person? Greater than what percentage? 98%. 98% is great, but actually normal is actually anything greater than 94%. Okay? But if we kind of look at this, 94% is about here. Okay? We start getting really itchy at 90, because pretty much less than 90%, you see that the bottom kind of drops out as you start desaturating. Okay? So the reason why we want to balance some of our oxygen therapy is because of this. Okay? We're trying to support this because we don't want them to drop down here because it makes it awfully hard to get them back. Okay? Okay, so how do we determine whether the airway is good? Do we need to do anything for this patient? So, we all have this concept as athletic trainers. We go and we have that easy ability. If I run out in the field, the patient's usually conscious, fine. They're talking to us. We don't even think about our primary assessment. We just pretty much go straight on to our secondary assessment. Hey, what'd you do? What hurts? Where is it at? We go and do our thing. But we take the primary assessment for granted, making sure the area is patent, breathing is adequate, circulation is adequate, okay? But obviously we gotta see, are they conscious? Okay, a person who's conscious typically has a clear airway. Okay, that perfect thing of going, hey, what happened? Oh God, my leg, oh God, my leg's broken. Yeah, okay, they're alert, they're oriented, they're moving air well enough, and they're obviously having good enough circulation to be conscious. Moving on, right? But when they don't give us that, then we have to go and work through that. Okay, so if they're unconscious, we go back to our CPR, our first aid classes, stuff like that, and we go and say, okay, we're gonna do our tap and shout, all that fun stuff, and we're gonna open that airway. Okay, what are our two go-to moves with opening airways is manually? Head tilt, chin lift, and modified jaw thrust. Okay, and even research is really starting to go and take some big swings at the head tilt chin lift, and it doesn't work as well as we think it does, which is all the more reason why things like our airway adjuncts are so helpful. Modified jaw thrust, though, is one that is a really, really good option. It gives really good control because of how it works. The problem is, now you're chained to it. You're now stuck there in a one-person system where a lot of times we're going to be that first person there. We maybe have a couple of people around us that we trust enough to help. We can now go, and now we're limited if we're doing that jaw thrust. Okay? But you'll still see as we come along a little bit later with some of the stuff, how it opens the airway a little bit better and why it is kind of a superior option. But at the same time, we have to balance it against what do we have available. Okay? Obviously, we look, listen, and feel for 5 seconds, but no more than 10 seconds. Okay? So we want to see if that chest is rising. Do we feel air coming against our ear and our face? Do we hear it? Okay? Obviously, we're beginning CPR if we are not getting breathing, and certainly if we don't have a pulse, or if the breathing is inadequate. If they are, if they're breathing or they're not really breathing well and they have a pulse, obviously we need to do positive pressure ventilation. Okay, so either rescue breaths with a pocket mask or something like a bag valve mask. We do have to go with that little asterisk in our mind. As soon as we have any depressed level of consciousness, we have to think about controlling that airway. As paramedics, we have a background, a little mnemonic that we tell ourselves when we go look at the Glasgow Coma Scale. And once again, I think we've all learned about in school, but we've never really used since. But we have the joke of less than 8 intubate. Okay, so if your level of consciousness is depressed to a level of 8 or lower, you're probably not going to be able to control your own airway very well, and we want to get really good control over it. Okay, so the idea is that if you're not able to be alert and conscious enough to protect your own airway, you need to start thinking about doing that for them. With the caveat that remember that the sequence is not ABC anymore, it's CAB in emergencies. It's circulation because things like major bleeding and them not having a heartbeat takes precedent over airway control. Okay, so that's what I'm saying. Like, we need to consider this beyond manual maneuvers, but not until we've made sure that quality chest compressions are in place, that major bleeding has been controlled. Because if you don't do that, all of this is just putting on a show. Okay. Questions, comments, concerns so far? Okay. So we've all kind of seen the sequencing that we've at the basic life support levels, essentially the perpetual circle of chest compressions and ventilations, AED. You just keep doing that until the patient becomes responsive or EMS arrives, right? So on the flip side, we as paramedics, our sequence looks a little bit different. Okay, and I bring this in to kind of show where we prioritize airway management. Okay, so I come in, I see CPR is in progress. I'm going to verify that it still needs to be going on. Okay, and then I'm going to be getting oxygen involved if it isn't already. I'm getting a monitor on. I'm going to make shockable or are they not shockable? Okay, if they are shockable, okay, I'm dropping a shock. I'm doing another 2 minutes of CPR. Are they still shockable? Yeah. I'm going to drop some meds, and then I'm going to consider an airway. I'm at least 2 minutes into CPR before I'm dropping an airway. If they're shockable. If they're not, obviously, I'm more behind the 8 ball. I'm dropping meds, starting the airway, and then I'm doing that because now I need to try and get caught up. Paramedics, we talk about here they talk about reversible causes. Okay, reversible causes over here we call the H's and T's. Okay, things that are going to kill you, but I can fix it. Okay, things like hypoxia or low blood hypovolemia, low blood volume. I'm going to give different things to try and fix some of these things. But the idea that airway adjuncts help me do that. Okay, but they're not my priority. My priority is good quality chest compressions and doing other stuff first, and then it follows along with it. Okay. How do we choose an adjunct? Okay, I've got this whole kind of bag of stuff. There's all kinds of things out there. What do I use? When do I use them? Okay, mechanism of injury has a major bearing on this. Okay, for a long time, you were told that you shouldn't even use certain types of airways if someone got their face smashed in. Okay, because and the interesting was it came from essentially one case in like 50 years. Someone put a nasal airway into someone's brain because they had a maxillofacial fracture. The problem is, for 50 years, EMS has been taught you never place a nasal airway because of that. And then a couple people went and researched it and went like, yeah guys, this is a one singular case study, and if you do the thing right, it doesn't happen. So, but we still go, it gives us considerations, okay? As well as a huge thing that tells us how aggressive I need to be with my airway adjunct is how likely are they to vomit. And that's where I'm going to go and talk about certain airways a little bit later that are ideal for things like day surgery, but not as good for us out in the field pre-hospital where we don't know what they've done and they haven't been kind enough to be not eating for the last 12 hours. All right. Gag reflex is a huge thing that tells you what you can and can't do. If they got a gag reflex, you have one option. If they don't have a gag reflex, you have all of your options. Okay? Obviously, level of consciousness is going to give us an indication on this. All of you have a gag reflex right now because you're alert and probably have an intact central nervous system. All right? But as soon as you become unconscious, now I may or may not have it. And you don't want to just go, I hope they don't stick something in there and go, oh God, and then you're having to go and suction and go and clean them out because they have a gag reflex. Quick and easy way to check that without having to root around in their mouth is to check their corneal reflex. Okay, it's at the same neurologic level as the gag reflex. You do that by tapping or flicking their eyes, okay, not the card, you owe me money. No, it's the idea you can run your fingers along the eyelid or tap the eye gently. And if the eye twitches or flutters, that's an intact corneal reflex, and you can very well assume they have a gag reflex. If they don't have one, you can go and say they probably don't, but you still have to be ready for it. Oh wait, no, they did. Because we all know those people who can put contacts in and never have a problem, and there's that person who's like sitting there with like a car jack holding their eye open to try and get it because they have a very sensitive corneal reflex. All right, so it's a quick little check that you can simply and easily do to get you an idea of whether or not they may or may not have a gag reflex. Okay. Also, the availability of the equipment. Okay. Sure, in your mind go, gee, I'd love an eye gel, but you have a nasal airway and an oral airway, and those are your options. So obviously, that's going to dictate your choices as well. Also, whether or not you have a bag valve mask. Certain ones of these airways have to be worked by a bag valve mask. If you don't have one, you can't use them. Okay? They don't work so well when you just put your mouth on them. Okay? Do you have suction devices available? Okay? If you don't have suction devices available, you should probably be less aggressive in your airway management because you don't want to run the risk of, oops, oh God, they're starting to puke, and now you have nothing. Okay? And as I said, the airways themselves, you can't use something that you don't have with you. So types, what do we got? We got the nasopharyngeal airway, okay? Well, we talked about the anatomy. This controls the upper airway. We have the oropharyngeal airway, or the OPA, which is like a hook that goes into the mouth. We'll go through each one of these a little bit more so in a bit. Then we have another class called the non-visualized supraglottic airway. Non-visualized means, okay, I just stick it in there, I'm not looking. Like a paramedic or a doctor who's using a laryngoscope, I actually put like a blade and a flashlight and I'm looking for the vocal cords. It's where here you just boop, drop the thing in. Okay, and supraglottic means it sits above the glottis. Okay, a couple of different subsets within the supraglottic airway. We have the LMA, or the laryngeal mask airway. I want you to kind of think of this as there's an earlier generation of these, and there's a new form of them that have come out that kind of have surpassed them. And those are basically things like the I-gel. Is that kind of newer generation LMA. We have the combi tube, or what's, if you're talking about a brand name, or just generically, it's a dual-lumen or a two-tubed supraglottic airway. And then the single tube form of it is called a King LT. It's kind of been the newest kid on the block, at least until the I-gel came along. Getting a little bit more advanced, there's endotracheal intubation. Okay, this is stuff like, once again, things that paramedics, doctors can do, get really controlled airway management. And then the most aggressive form is called a surgical airway, where someone cuts a hole in your throat and ventilates you that way. Okay, this is really good for when we have something like using that allergic reaction kind of problem, where the person is having anaphylaxis, and I cannot physically get a tube or anything else through it. You cut a hole, you bypass it, and you just start ventilating the lungs that way. Okay. Okay, so getting into our airways. Okay, so the MPA looks like a little tube, usually made of like a rubber or a silicone, and it once again controls from the nose to the mouth. A couple pros to it: it is great for that semi-conscious patient, or that patient that has a gag reflex. I could drop a nasal airway on any one of you right now. You won't like me while I'm doing it, but I could do it. Okay. So you think about that patient who has got that altered level of consciousness, like they've been hit in the head. They're not completely knocked out, or they're semi-conscious, or they knocked out but they're maybe starting to come to. Someone who's had a seizure. Okay, these are great airways for them, because once they regain consciousness, they're just going to be like, oh, what's this thing in my nose? But they're not going to reject it. Okay, but you still have that control over the airway. Okay, extremely fast, extremely easy. Very, this is actually one of the airways I've used probably the most in my career. Cons, all right? It used to be you couldn't. Now the answer is you should just be careful if you have facial injuries with these, because once again, you don't want to snake this thing up into a sinus. You don't want to stick this thing into their brain if they actually had something serious. But that's where we're still evaluating those patients. Is there cerebral spinal fluid coming out? You know, are they getting facial elongation? Any of those things really? No, that doesn't look right. The other thing too is that depending on how the thing is sized, you may not get as much control over the airway as you can with something that goes and protects something lower. Okay, so it's kind of a trade-off. I get some, but it's not great. Okay, so actually, how do we place one of these suckers? Okay, quick little video. There's a community college in Wisconsin that makes some really good videos. It's the Waukesha Community College, so I actually used quite a few of their videos.
Nasopharyngeal airways are simple to insert and can be used in both responsive and unresponsive patients. In instances where an oropharyngeal airway adjunct cannot be used, a nasopharyngeal airway may be a good option. Nasopharyngeal airways are produced in a variety of sizes to accommodate various patients. To select the correct size nasal airway, begin by visualizing the patient's nares and select a nasal airway with a diameter slightly smaller than the patient's largest nare. Once the diameter is determined, then measure the device from the tip of the patient's nose to the tip of the earlobe or angle of the jaw. The rubber washer or grommet can be slid back and forth on the device to ensure a proper fit. Lubricate the distal surface of the airway with water or a water-soluble lubricant. If inserting the nasal airway into the patient's right ear, insert so as to follow the normal anatomical curvature of the nasopharynx with the bevel toward the septum. Direct the nasal airway along the floor of the nose into the oropharynx. If inserting the nasal airway into the patient's left ear, it is necessary to invert the airway so the bevel of the airway remains along the septum. Once the nasal airway reaches the nasopharynx, rotate the airway 180 degrees to resume alignment with the normal anatomical curvature of the nasopharynx. Continue to insert the nasal airway into the oropharynx. Once the nasal airway is in place, the last step is to check for adequate air exchange.
Okay? So generally speaking, most nasal airways are designed so to go into the right ear, because the original assumption was the right ear was always bigger. That's not always true, because they have actually debunked that through MRI studies, but they're still designed that way to start in the right ear. It doesn't matter which one you go with, the bevel always needs to be, essentially the cut of the tube needs to be towards the septum. If you go in through the left, you go it's about half. You'll feel that there's a little change in resistance as you clear the palate, and you just turn 180 degrees, keep advancing it. Okay? And remember, here we talk about always using water-based lubricants. Granted, we as athletic trainers, we all walk around with Vaseline in our AT bags, but that's petroleum-based. Petroleum-based products can actually cause irritation and damage to the mucosal membranes. Even though, once again, as athletic trainers, how do we plug a nosebleed in wrestling? You lab that thing up with Vaseline and stuck something up in there. But realistically, those deeper structures really don't respond well to the petroleum-based products. It causes an irritation. And next time you're not sure about that, if you get gasoline on your hands when pumping gas, I wouldn't recommend. That's why you don't leave it on your hands, because actually, once again, it can injure the skin as well. Okay. That was an adjustable length that had a little ring to it. There's other ones that don't have that, and sometimes you have to think about getting other sizes. I like that one because it's a little bit more versatile based on sizing.
What's the downfall if you go on the left side and you do it the wrong way? Like, is it still going to end up in the right spot because it's flexible, right? Or is it going to really...
Yes and no. You saw that it's got a curve.
Yeah.
Okay, if I don't turn it at the right point, I can actually end up feeding that into a sinus. Or it gets stuck up in like the upper and the nasopharynx, and it doesn't ever pivot down. And at that point, I'm creating a lot of ventilation up into the sinus, but I'm not getting that control deeper. So it's one of those things that it's theoretically possible. I mean, most people, if you make a turn in the right place, it's not a big deal. It's more of you just want to turn it too late. If you turn it early, it's once again not going to necessarily be as big of a deal. The problem still becomes of why you just don't do it anatomically on the left is because of the bevel. It can get caught and then start going and bending elsewhere because it is so flexible that now I can start going into like a facial sinus instead of like a frontal sinus. Okay, the idea is I want to follow that airway all the way down through its backwards. Okay, so pretty much as long as you're staying parallel to the palate, you're good. Okay. Okay. In our OPA, as I said, it's like a hook. Okay, and it does an extremely good job of controlling that tongue because it essentially hangs off the teeth and keeps the tongue off the back of the throat. Because that is one of the biggest airway obstructions we get once we lose consciousness because the tongue slides back, especially when we're supine. Okay. It also, if left in place with a more advanced airway, it acts as a bite block. So that way, let's say the patient starts seizing some of that, they don't start, Mike Tysoning through the tube. Once again, very fast, very easy to place. Downside, cannot use this with a gag reflex. Okay. Because if you put the thing properly, it's going to rub against the back of the throat. Okay. How do we place these? The video is going to show pretty much one option, or they're going to show two. There's actually three options of how to place this. I forgot that they have like 15 minutes of. It's like a Disney movie.
When managing the airway of an unresponsive patient without a gag reflex, oropharyngeal airways are a good choice. As always, be certain to wear appropriate body substance isolation when managing a patient's airway and begin with manual airway maneuvers first, such as a head tilt chin lift or a jaw thrust for those with suspected spinal injury. Oral airways come in a multitude of sizes, so the first step to using one is to determine the correct size for your specific patient. The way to determine the appropriate size oral airway for an adult patient is to measure the airway against the side of the patient's head. The oral airway should extend from the corner of the patient's lips to the bottom of the earlobe or the angle of the jaw. Once the correct oral airway is selected, open the patient's mouth using a cross finger or scissor finger technique. The airway is then inserted into the patient's mouth with the tip pointing toward the roof of the mouth. Once the airway touches the soft palate, rotate the airway 180 degrees into anatomical position with the flange resting against the lips or teeth. As another option, the rescuer can also use a tongue depressor or other similar device to move the patient's tongue forward and down. The oral airway is then inserted into anatomical position so as to follow the normal curvature of the oropharynx until the flange rests against the lips or teeth. Once the oral airway is inserted, check for adequate air exchange.
So they showed two different ways. On our mannequins, the 180 approach cannot be done. The mouths do not open large enough for you to be able to pull that off. Okay, so don't even try it on the mannequins today. You'll just get frustrated. And they showed the anatomic placement. This is an ideal placement for younger children because their mouths are smaller and their tongues are proportionally larger in the mouth. That approach works the best for smaller children and smaller people. Now, they go and say, oh, use a tongue blade. Okay, that takes time and energy. Guess what? I like using what I call the big mouth bass method. You stick your thumb down under the tongue, you grab a hold of it and push it down into the floor of the mouth. Essentially pinching against it to the bottom of the jaw, and you pull and lift away. The third option that they didn't show, the one that I actually prefer for placing this type of airway, is called a 90-degree placement. Okay, so you come in from the corner of the mouth. It's usually my right hand, so I have the tip towards the right cheek. Kind of come in until it's pretty much all the way in, and you turn it 90 degrees so that then it points down. I find that one works really well for just about anybody, because the problem with the 180-degree placement is if you don't get control of the tongue well enough, you never actually end up hooking the tongue. And depending on how deep you go, you run the risk of creating some trauma on the back of the throat as you twist that thing into place. It's one of the reasons why I like the 90-degree and the anatomic a little bit better. Okay, I feel like I guarantee I get control over that tongue and there's a little less trauma in the airway. But situations give you different things. Knowing that you have different options, you can choose between those and use your clinical judgment as to which one you think is going to be best for this patient. But like I said, for today with the mannequins, the 90-degree and the anatomic placements are going to be the ones you're going to want to use. All right, and the jaws are pretty stiff on those, so you can do the little scissor method, but you're not going to get as much opening as you would in a real human being. So that's once again for them, I kind of like going and using the big mouth bass as option. Laryngeal mask airway. So these are the early first generations of these suckers. The pro is that they have a single tube that you have to worry about. Okay, and you'll see why that's a pro when we look at the combi tube in a minute. All right. Okay, that's the only good thing I had to say about them. All right. They're super easy to dislodge. There's nothing anchoring them in the airway. They're just essentially sitting over the top of the glottis. Okay? There's nothing holding these suckers in place. They had unreliable patency because guess what? They're not a patient who's just sitting there lying there getting a procedure in a surgery bay. We have patients that we're going to have to pick up and we're going to have to move. And we're going to have to go upstairs, downstairs, and transfer from gurney from ground to stretcher to hospital gurney, and later on, these things came loose. Okay, they didn't have any way to decompress the stomach or do anything for the stomach because once again, they're designed for somebody who hasn't eaten in the last 12 hours. Okay, but then people went, well, geez. The logic of how this thing works makes sense, but how can we make it better? And then in the last couple of years, there's been the eye gel that has come onto the market, which essentially took all the good characteristics of the LMA, of the conceptual stuff, and actually fixed some of the stuff that didn't work or wasn't that great about it. Right? This is the company that makes them. This is their video, and so obviously, of course, they're gonna be a little rah-rah, our stuff's perfect. Okay. But they do actually have a pretty nice product. And they're European, so prepare for British.
Which is soft. iGel is a novel and innovative supraglottic airway management device made of a medical-grade thermoplastic elastomer, which is soft, gel-like, and transparent. It took over 5 years of development to perfect a non-inflatable anatomical seal of the pharyngeal, laryngeal, and perilaryngeal structures that would reduce compression trauma. A supraglottic airway without an inflatable cuff has several potential advantages, including easier insertion, minimal risk of tissue compression, and stability after insertion. iGel is a latex-free single patient use device that has a gastric channel to reduce the risk of aspiration. Key components and their function. The soft, non-inflatable gel-like cuff matches the shape and softness of the laryngeal and perilaryngeal framework. It helps to provide easy and rapid insertion and reduces the potential for post-operative trauma. An integral gastric channel is provided to reduce the risk of aspiration and allow for passing of a nasogastric tube. The buccal cavity stabilizer eliminates the potential for rotation and aids insertion. An epiglottic rest helps to prevent the epiglottis from downfolding or obstructing the distal opening of the airway. The 15mm connector extends inside the airway tube far enough to provide an integral bite block. Pre-insertion preparation. iGel is supplied in a sterile pouch enclosed in either a protective cradle or a cage pack. This innovative packaging is color-coded for size and designed to ensure the device is maintained in the correct flexion prior to use. It also acts as a base for lubrication. Select the appropriate size iGel according to patient weight. When selecting size, it should be remembered that the iGel cuff does look smaller than the corresponding size of many traditional supraglottic airways with an inflatable cuff. Ensuring that you conform to local policy for hygiene, open the iGel package and on a flat surface take out the protective cradle or cage pack containing the device. In the final minute of pre-oxygenation, remove the iGel and place a small bolus of a water-based lubricant, such as KY jelly, onto the middle of the smooth surface of the cradle or cage pack in preparation for lubrication. Do not use silicone-based lubricants. Grasp the iGel with the opposite free hand along the integral bite block and lubricate the back, sides and front of the cuff with a thin layer of lubricant. This process may be repeated if lubrication is not adequate. After lubrication has been completed, check that no bolus of lubricant remains in the bowl of the cuff or elsewhere on the device. Avoid touching the cuff of the device with your hands. Place the iGel back into the protective cradle or cage pack in preparation for insertion. Do not place the device onto the pillow or chest of the patient. Always use the protective cradle or cage pack. Do not use unsterile gauze to help in lubricating the device. Do not apply lubricant too long before insertion. And always ensure dentures or plates are removed from the mouth before attempting insertion. The iGel must always be separated from the protective cradle or cage pack prior to use. These are not introducers and must never be inserted into the patient's mouth. Insertion technique. A proficient user can achieve insertion in less than 5 seconds. Remove the iGel from the protective cradle or cage pack. Grasp the lubricated iGel firmly along the integral bite block. Position the device so that the iGel cuff outlet is facing towards the chin of the patient. The patient should be in the sniffing the morning air position, with head extended and neck flexed. The chin should be gently pressed down before proceeding to insert. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force on the device during insertion. It is not necessary to insert fingers or thumbs into the patient's mouth during the process of insertion. If there is early resistance during insertion, a jaw thrust or insertion with deep rotation is recommended. When inserted to a definitive resistance, the tip of the eye gel should be located into the upper esophageal opening, and the cuff should be located against the laryngeal framework. The incisors should be resting on the integral bite block. The eye gel has a horizontal line on the integral bite block to indicate the optimal position of the teeth. But the teeth may rest safely anywhere on the integral bite block. The eye gel should then be taped down, maxilla to maxilla. When inserting the eye gel, it should be remembered that partial resistance and then a feeling of give way may sometimes be felt before the endpoint resistance is met.
I'm going to scroll it back. You actually see that throat pop up, you see it actually seat in place.
But the teeth may rest safely anywhere on the integral bite block. The eye gel should then be taped down, maxilla to maxilla. When inserting the eye gel, it should be remembered that partial resistance and then a feeling of give way may sometimes be felt
seating in place.
Endpoint resistance is met. This is due to the passage of the bowl of the eye.
Okay. So, very good control. It's a very nice device, and it's getting used to it. It's just getting more traction here in the U.S. Downside is you saw that it took 2 people to put this airway in. That is its big drawback. It's that it is, as nice as it is, it does really need 2 people to place it properly, because it's designed for a surgical environment. But right now, this is it's being shown as one of the more gold standards of the supraglottic airways. So, okay. Unfortunately, I don't have any of those to play with today. That's why I had such a long video, because I wanted to be able to kind of demonstrate it, and then we'll move on. The combi tube. Okay, so this is what I learned on many moons ago as an EMT, because this is what we had. Okay, so it has 2 tubes up top, but it fuses into a single tube below. You'll see these when we get to play with them a little bit later. So the idea is that you hoped and dreamed that you would end up in the trachea and essentially be like an intubation. The problem is that no one could ever do it. Okay, when the department I worked at, we had a jar. When you were actually cleared to be out on the road, you bought in with 10 bucks. You put it in the jar. If you could ever get a tracheal placement on a combi tube, you could win the entire contents of the jar. All right, I think when I started there was about $800 in there. When I left, there was about well over $1,000 in there, and I still think it's growing. Because the natural anatomy means I'm probably going to end up in the esophagus, but that's okay. It seals off the esophagus, and there's little holes in this part of the tube, so that if I'm ventilating and I'm in the esophagus, the air just comes out, hits this big bulb over here, and then goes down into the trachea. Okay, that was the logic behind it. But because it almost always ended up in the esophagus, the second tube actively decompressed the stomach. Okay, so that person who's just been doing CPR, or bystanders who are just going and blowing way too hard, and they're just filling that stomach up. And of course, that guy just came from the concession stand, and he's waiting to kind of blow panel 1 of Sonic's menu all over you. Because someone's too aggressive with their CPR, helps decompress that. Okay? Okay, so the pros, like I said, it created that passive decompression of the stomach. Okay, I could go and even stick an NG tube down there, and I could suction up the stomach if I really wanted to. Okay, like it was an overdose or something like that, and I really just wanted to get everything out of there. Okay, it was wonderful. Very, very stable, because when we play with this, you'll see how big that balloon was. Once that thing inflated and filled in the mouth, it really wasn't going anywhere. All right. The cons, unfortunately, once you inflate that balloon, you have no access to anything behind it. So if you're a little aggressive in your airway placement and you ripped up the back, or they're having other types of trauma or bleeding or secretions, can't do anything about it without completely dislodging the airway. The other problem was it was time consuming. It's a big motor, it's got 2 syringes on it, and you gotta go and work with them, and you got lube on your hands and to do stuff like that. It was hard to not place this airway quickly. And national guidelines say that we need to have, we should never interrupt our ventilations for more than 30 seconds. So I've got a 30-second clock to put in an airway. I'm using all 30 seconds with this sucker, possibly more. Okay. I'm going to skip the video of the combi tube just because we're getting a little bit close to the time where I wanted to break. We'll kind of go through the combi tube stuff and actual skill demonstration during the lab practice just because of the size of the stuff that we have. All right. Then also, I've been using this video for a couple years in the EMR class, and I'm not a huge fan of its quality. But I have it in there so that we have it available. All right. The King LT. So like I said, the combi tube came in and I'm like, oh, hey, this makes sense. This is pretty good. But, it's got some problems. And so I'm, well, I'm going to make a better mousetrap. And the better mousetrap was the King LT. So we took all the concepts of how a combi tube worked, but we said, okay, screw it. We're never going to get the tracheal placement. Okay, let's just build the thing to automatically go into the esophagus. Okay, and I'm going to make it with 1 tube because I'm never going to get the tracheal one. I don't need the second tube. So we stripped it down to 1. Okay, so same device. So like I said, everything that we loved about the combi tube, but it made it less cumbersome. Okay, faster placement. Okay, those of you who did take my class previously know that I had some rules for you guys in this one. But you guys, I've added a extra credit for them in their practical exam. They have to be able to place this airway blindfolded within 30 seconds for a point of extra credit. And so far, out of the last 3 or 4 classes I've done it, only 2 students out of all of them have not been able to place it within 30 seconds, blindfolded.
Have not been able to.
Have not been able to.
Ooh.
So I have like 9, that's a trap, Jason. It's the fact that pretty much 98%, let's just call it 98% of my students are able to do this in 30 seconds or less, blindfolded. Because you don't actually have to be able to see what you're doing. Because you think about it, you got people, you've been doing CPR, you're sweaty, it's raining, and it's doing something like that. You're going to have something going, you can be able to place this airway in the middle of the field under stress by pure muscle memory if you get enough practice and repetition with this. Okay? The cons, okay? Once again, because that huge oropharyngeal balloon, I can't suction this airway once this thing is in place. Okay? I put the thing in, what's going on in there is what's going out. Okay? And the initial models of the King LT that were designed for things like day surgery didn't have a way to work on decompressing the stomach. There are ones that do have that, and you'd think that'd be the one that's the easiest one to get. No. The ones with that port, so you can suction and do stuff with the stomach, cost about another $30 to $40, and they're harder to find. And through the different supply houses that I'm aware of within EMS. So, once again, balance. It still gives you pretty darn good control, but some recent studies that we'll kind of talk about here in a moment have problems because it doesn't give us a reliable control. This is an embedded video that I made for grad school, so I'm not going to play this because you're already hearing me enough for 3 hours. You don't need to hear me on video. Plus, I have there's 2 kryptonites I have. Me, I'm seeing someone like my wife cry, and seeing or hearing myself on video. And so, once again, it's there if you need it. This also shows the placement of oral airways, nasal airways, King LT, and combi tube as a whole set. I'm not going to play that whole video. Once again, we'll go through that as well. Okay. Endotracheal intubation, just kind of rounding out the airways that we have. The pros, it gives us complete control of that airway top to bottom. All right. No question marks, no things of what's going on. Okay. Should I need to, let's say someone's got a lot of secretions and stuff in their lungs, I can actually stick a tube down there and I can suction out the lungs directly. Downside, well, it's outside of our scope. We can't do this. Okay. They have to be visualized, and the problem is this skill deteriorates rapidly. That's actually one of the reasons why in EMS there's kind of a bit of a war going on right now as whether or not paramedics should actually still be allowed to intubate. Because we don't get to do it as often as we want to. And when we got things like King LTs, combi tubes, IVs, the iGel, especially with the iGel now, as far as like, why? To other than we go, but it's awesome, and I get to bust this thing out, I get to have this kind of cape action going on. There's nothing to support it. And then something else too, is that there's even studies that are coming out and saying that the supraglottic airway is potentially superior to the endotracheal tube, okay? It was 72-hour survival in post-cardiac arrest, and that's coming from out of the Journal of American Medical Association, okay? But it's close, it's near equal, and there's still some people saying there's some issues with this study, like because it was the way they randomized, that it's maybe not inferior, but it's maybe equal. It's still a bit of a knife fight. But then we're also going and saying, okay, we're talking about your metric was 72-hour survival, not positive neurologic outcome. Because let's face it, I don't care. Obviously we want people to live, but we kind of want people to be alive and still like functioning. Not, well, I kept them alive for 3 days, but they're on a vent and they'll never come off of it. And so once again, this is where we're still looking at how can we keep improving resuscitation science and sort of the battle for the soul of airway management right now. And then lastly, the surgical airway. All right, so we get something like, this big hunk of, I'm guessing, possibly cheese or a rice thing. I'm not sure what this thing is over here, but they can't get that sucker out, or it's a tumor or anything else. I don't know too well. You actually cut a hole, we as paramedics, we feel for the thyroid cartilage. We strap down just a little bit, find that little space underneath it. We cut a little hole right there, put a tube in, shazam, we've got a working airway. All right, pros. Okay, I get some really good control over that airway. Con, definitely outside of our scope. Okay, I used to make the joke when I used to take CPR classes. Just because you saw it on TV and you got a steak knife and a big pen doesn't mean you should go and do this. Okay, the Good Samaritan law won't protect you. All right, and as I said, because I'm cutting you, it's kind of evasive. there's things that can go wrong. All right, but it is an option of last resort. Okay, but wait, Brian, it's not that simple of just choosing some of these airways. Okay. Recent studies have said that not all supraglottic airways are created equal. Okay. The newest generations of laryngeal masks, I said, like the iGels, are showing the greatest promise right now of their stability and control and protection of the airway right now. The King LT was indeed king for a long time until the new generations of the laryngeal mask came in. Because we're finding that they don't have the reliable maintenance of the negative interthoracic pressure. Essentially, when we do chest compressions and stuff, are we actually getting a drop, enough of a vacuum in the chest? Because we want to improve stroke volume as we do each chest compression, removing the most amount of blood per pump. That the King LT and the combi tube don't give us that kind of pressure we used to think they did. Especially because they can theoretically move slightly within the airway, and sometimes that millimeter here or there is the difference between a good solid vacuum and not having that vacuum. Okay, so these are things that are, once again, we're looking at, because also we're going, why are we looking at survivability as opposed to positive neurologic outcomes? And once again, it's getting down to methodologies. How much do they cost? This is the last thing, and then we're going on a break. Okay, so a kit of 5 to 7 nasal airways, okay, of various sizes, so you can get really, really narrow to really, really thick. Can be anywhere between, when I was a quartermaster in Indiana, I used to do supplying resources for the department I was with. We used a company called Common Sense, as in change, Common Sense EMS supply, out of Connecticut, and their website is savelives.com. You can get anywhere, depending on material, somewhere between $17 and $35 for a kit. These things really don't expire. You can throw them in your AT bag and they'll pretty much be there forever. For the nasal airways. They are available on Amazon for $15 to $30, depending on, once again, what material you're going with. The OPAs, there's 2 varieties of those. There's ones that have essentially little channels on the side of them, called Brennan kits. That's what we have here and we'll practice with today. But there's also called, of course, blanking on the other one, but essentially it's a tube. So the advantages of that one is that you have known value of having a tube of where you're moving air, where the one with the channel is really nice for suctioning, because you can essentially just ride that sucker down and do some suctioning if you have to. Right? Once again, a kit for that, $3 to $7 on SaveLives.com. It's all 7 sizes. You keep them in your kit. They're single use, but once again, they never expire. They're there. They're ready for you if you need them. And once again, about $5 to $15 on Amazon. Okay, but the difference is on Amazon, okay, you can be like Prime member and your shipping's taken care of. SaveLives.com, your shipping's not included, so kind of balancing that kind of stuff out. Looking at the eye gel, the good news is the eye gel is actually pretty cost effective. Okay, I was actually surprised on that one. I was expecting it to be a bit more, but I was actually finding it for somewhere between $20 and $25, depending on the supplier that you find them through. But then you got the King LT, and like I said, this is the one that without the suction port or anything that does for the stomach, $48 to $78 are the 2 places I found them. Okay. So, all right, suctioning. So there's basically 2 types of ways that we can suction the airway. And we're going to do this to remove things like blood, mucus, vomit, anything else that's in that airway. And we can use that with a handheld device where the suction is created by us pumping, or a mechanical device that's powered by a battery that creates its own vacuum. Okay, so like I said, mechanical kind of looks like this. Okay, there's usually a bigger vessel container that you attach to it. Usually have about a 1 to 1.5 liter capacity. You can connect tubing to it. You can kind of go nuts with that. Really, really nice option. Problem is, they're big, they're heavy, and they're expensive. Okay, you got to keep the batteries charged, so it's not always really cost effective for us as athletic trainers who are going out doing per diem work. Okay, so the manual hand operated options, and there's a couple different variants. I carry the VVAC just because that's what I had access to, as opposed to some like your Ambus and your Lordells. I'll make some different varieties. Okay, they're all have pros and cons to them. I feel that the Ambu ones are nice because they got a little, the containers are easier to change and they're bigger than the Lordell type. Now Lordell also makes the VVAC, and that's what I carry because that's what I have. The downsides to it is that if you get really aggressive with your suctioning, the valves that pull the water out or whatever you're suctioning out also seem to leak. As I have, as I teach them, I use them in this class all the time, and I just use water. But eventually, the water starts kind of spraying in a few places as I'm suctioning out that. We're not going to do suctioning on the mannequins today because that means that is a special mannequin I have to set up, and that's more trouble than it's worth sometimes. Anyway, though, you have different catheters, so there's usually big gauge ones where you're trying to get the big, thick industrial waste kind of puke, down to really small, flexible ones you can snake through their nose. Okay. From an airflow standpoint, guidelines say that you should be able to pull about 40 liters per minute in terms of airflow through it to be effective, and it should be able to create a vacuum of greater than 300 millimeters of mercury when clamped. Okay, so it should be able to pull with a certain amount of force for it to be good enough. Because some people go and say, well, Brian, can't I just use something like a turkey baster? And the answer is, well, sort of. Okay? While the logic of it makes sense, and some of the original types of suctions were based on stuff like that, the problem is the hole isn't big enough. Okay? You're not going to get the suction levels, you're not going to get the flow rates that you're really supposed to be able to get. But if you had an emergency and you need to do something like that, you could, but it shouldn't be the way you go about it. These actually commercially made devices are kind of what you should use. Okay? Price points of these are actually pretty reasonable because the handles, you buy once and they're yours forever. Okay, the replacement parts are the ones that get sometimes a little more tricky to track down. So like an initial kit's usually something like $40-50. But once again, then the odds of you ever using them are relatively low, and then a replacement cartridge is like with a VVAC, they come in 2 packs. Like a 2-pack refill is like $10. So not anything significant. How do we suction? Okay, we have to measure the length like we would in an OPA or an MPA. Okay, so we're going from the corner of the mouth to the ear, or nose is the ear, depending on what we're doing. Okay, pretty much if you can't see the end of it, you've gone too far. Okay, it's like my daughter. If I can't see her, there's something going wrong, and something's going to happen. Okay, so you got to be able to see what you're doing. Okay, we should pre-oxygenate the patient So that means actually ventilate them, get them their pulse oximetry above 94%. Okay, so we'll come back to that bell curve so that I keep them well above it, and I've got some room to work so they don't get close down to 90, and then bottom drops out. Now I'm going to be behind the 8 ball. Okay, that's kind of that logic to keep them, kind of top them off, and go from there. One of the tips I give my students when we're doing airway management, like I said, we can't interrupt ventilations for more than 30 seconds. Okay, I tell people when you're learning, hold your breath. If you got to take a breath, so do they. Stop, reventilate them. Okay? Because think about it. You're going to be, if you're actually going to do this, your adrenaline's going to be through the roof. You're going to be, oh my God, oh my God, oh my God, oh my God. Okay? You're not going to be able to hold your breath for more than 30 seconds in that scenario. I guarantee it. All right.
Just pass out.
but then we're breaking one of the cardinal rules of medicine. We don't multiply or subtract patients. All right. We insert the tip in, and then we activate the suction on the way out. So if it's a mechanical suction, usually there's a little hole or something you put your thumb over, okay, and that completes the circuit, and then it starts suctioning. Or if it's a manual one, it's actually when you start pumping, but you don't start suctioning until you're ready to go. You don't suction in, you suction out. It's in a sweeping motion, okay? We don't suction for more than 15 seconds. But Brian, you said you don't ventilate. We got 30 seconds. Yeah, but we're taking air out of them too when we're suctioning. So half of it. Okay. I'm going to show you 2 videos. Once again, just showing you suctioning technique with a rigid handle on a mechanical unit, and then a flexible one if you ever had to do it. They're like Disney. It's like, you know, like 2.5 minutes and some opening credits and some logos.
Mucus, blood, and other secretions can make it difficult for an unresponsive or otherwise incapacitated patient to maintain a clear, patent airway. In such instances, the EMT's best option is to use a powered suction device to clear the patient's airway. As always, be certain to wear appropriate body substance isolation when suctioning a patient. Rigid tip suction catheters can typically accommodate larger obstructions, such as pieces of food, than flexible tip catheters, which can make their use appealing in many instances. On the other hand, rigid tip catheters are more likely to cause trauma to the patient if used incorrectly. As a general practice, the use of rigid tip suction catheters is discouraged in a moving ambulance. Unlike the flexible tip suction catheter, there is no need to measure a rigid tip suction catheter prior to insertion and suctioning, as the EMT must maintain sight of the distal tip of the rigid catheter at all times. Once the rigid tip is attached to the suction unit, the EMT should turn the unit on and ensure proper functioning. Open the patient's mouth using a cross-finger technique, a tongue depressor, or other similar device. Ensure there is no suction at the tip, and insert the catheter into the oropharynx as deeply as necessary to suction the airway, so long as the distal tip of the rigid catheter remains visible. Apply suction and move the tip across the oropharynx for up to 15 seconds. Remove the rigid suction catheter while maintaining suction. Once completed, check for adequate air exchange. It may be necessary to suction multiple times. If necessary, flush the system with water between suctioning attempts to ensure adequate suction at the tip. Also be aware of large particles, such as pieces of food, that may obstruct the suction catheter.
My personal favorite, I sucked 3 teeth out of a guy's his airway once. You're like, oh, okay, we'll just drop those off. Moving on. All right, I'm going to skip the video for the flexible one. It's a very similar concept. Once again, you measure from the nose to the ear. You go through. The difference there is there's a little white handle on those. You put your thumb over that. That creates the seal, creates the suctioning. And once again, you just suction on your way out. And you definitely have to clear that with water every time. So it's like suction out, suction a little bit of water, lather, rinse, repeat. Okay, just because it's such a smaller tube, and usually you're pulling stuff out, especially from the nose and mouth. It's going to be like mucus, phlegm, blood. That stuff's going to tend to be thicker, and you will clog that thing up much more readily.
Measure a...
No, stop that. Yep. All right, so now we're into the oxygen component of this presentation, okay? So, times have changed, okay? back, when I went through EMT school, the answer was high flow oxygen, high flow oxygen, high flow oxygen. Oxygen can't hurt you, it can only help. Well, then we did some research about that and went, whoops. But high flow was our answer to everything, and it's not anymore. So we've actually found that hyperoxia, too much oxygen in the blood, not so good. Okay? For one thing, our bodies are designed to pull in about 21% oxygen at a time, because that's what ambient air is. Okay? Oxygen breaks things down, oxidation. We've talked about this in chemistry and stuff like that. When you leave a car outside long enough in Chicago, it turns to rust. Okay? Organic tissue can do the same thing. Okay? So we can see free radical releases in the tissue for up to 14 days after high flow oxygen exposure. Well, that's not good. Okay? We actually decreased cerebral blood flow and coronary blood flow with high flow oxygen. Well, geez, when we're having someone having a heart attack or something like that, that sounds kind of counterproductive, doesn't it? And we were actually seeing decreased survivability in cardiac arrest when we kept on using high flow oxygen afterwards because of those things. The free radical releases, the changes in the blood flow speeds, not helping. So, all oxygen therapy needs to be given or titrated to the effect of 94%. I need you to use just enough to get the job done. Okay? So we have very few ways we use high flow oxygen anymore. So let's say oxygen therapy is gone, we just don't go slap a downward breather on them, crank it to 15, and we're good. Okay? It's not like that anymore. Okay? So when are we going to give someone oxygen? Okay? Well, like that, if they're less than 94%, they're saturating at less than 94%, okay, we need to start thinking about it. Okay? Okay? They're complaining or giving us signs of respiratory distress. These are our classic things like our nasal flaring, our retractions, accessory muscle use. Breathing is not a full body workout. Okay? Your back muscles and your shoulder muscles were never designed to help you breathe. Okay? Cyanosis, okay? People are not supposed to turn blue. Okay? Pallor, okay? We all know some of our friends are a little on the fairer complexions, okay? But then there's a difference between being pretty pasty and that doesn't look healthy, okay? Breathing too fast or too slow, okay? So if we're breathing 4 times a minute, okay, not normal. Breathing 36 times a minute, not normal, okay? Abnormal breath sounds, okay, so we go and listen and go, I hear wheezing, I hear gurgling, I hear crackling, I hear nothing. These are all things that would be abnormal. So at those points, once again, we're coming back to those anatomy or physiology stuff, our pathophys. I'm impacting things like carrying capacity. I'm getting into some sort of level of hypoxia. All right, something is impacting this. All right, and maybe it's the minute volume. They're not moving enough, or per minute, or per breath, or whatever. I need to give something to help out in those in that time period. Okay, or complaints of shortness of breath, or the actual things of they can only tell you things in 2 or 3 word bursts. Okay, that's not normal. Unless you're shattered. Also, the mental status. Okay, once again, our brain is a big fan of 2 things: sugar and oxygen. Deprived of either, you will not like it when it is angry. Okay, so what do we have left of going, okay, Brian, we can't use high flow as much as we could anymore. When can we use it? Carbon monoxide poisoning. We are going to suspect these things in like smoke inhalation. It's not something we're going to have to see a whole lot as athletic trainers, hopefully. But definitely time we have to do that. Okay, and we'll talk about why a little bit more so a little bit later. But it gets into physics. Okay, once again, if you think about concentrations, okay, everything in physics is the more concentrated you are, the bigger you are. And it's like you're the big kid on the playground. You're going to be able to push people around. With more concentration of oxygen, I can push carbon dioxide out of the blood. Okay, that's why it's a useful treatment. Okay, decompression sickness or illness, or the bends. Okay, once again, something that we as athletic trainers are probably not going to be having to encounter very much. But I'm a scuba diver. I have to know how to give oxygen therapy if I think someone is bent. Okay, once again, it's the same logic. Okay, when you're underwater, you accumulate a nitrogen gas, and you start turning into a pop can. Okay, and like a 20-ounce bottle. When we open it up, we get that nice little we love that sound, we go and drink something nice and refreshing. But it's instead of just opening up and then it's okay, you drop the 20 ouncer and then you go and open it and then it just bubbles over. Well, imagine that in a human being, and that's what the bends is. The nitrogen and bubbles expand and they start creating problems. The pressure of the oxygen keeps those bubbles small and prevents them from expanding. Cardiac arrest with an asterisk until we get ROSAC, or return of spontaneous circulation. As soon as that heart starts pumping again, we got to throw out an anchor and start titrating to 94%. Okay? Because it comes back to the pathophysiology. The reason why we use so much oxygen when they're in CPR is because they need it. Okay? And I'm trying to control for pH. It's because they're going to be dumping so much acid because they're not getting oxygen. And the cells are getting deprived. I'm trying to keep that under control, but I'm also trying to dissolve extra oxygen into the serum. So that once again, as much oxygen is going to get to the tissue is going to get there. Okay? But as soon as that heart starts beating again and we start moving that, okay, as paramedics, we're looking for a very specific change in the monitor. We're actually looking for their carbon dioxide levels, and you'll see this huge spike. We call it the toilet flush. Just because we see all that waste product suddenly accumulate. When the toilet flushes, we need to actually be careful because now we don't want to keep circulating too much oxygen and all that free radical around. Throw out an anchor and start dialing back. Okay? And the profoundly hypoxic, that patient that's got a less than 90% O2 saturation, and they're getting us like, you know, they're blue, they're cyanotic, they look bad, they're approaching respiratory failure kind of stuff. Yes, get them a whole buttload of oxygen and get them up. But then once we get them back to about 94, once again, throw out an anchor and then dial it back or discontinue the therapy. Okay? How do we determine oxygen saturation? Okay? Well, we need a pulse oximeter. Okay? There's a couple different varieties of these. This is like a nice little hospital-based, hand-based one. These suckers are like $200. Okay? Where the little fingertip ones are actually pretty reasonable. I think on Amazon I've seen them for as low as like $30. Okay? Just when you get one, you want to get one that actually still shows a waveform. So that way that helps you verify the quality of your reading. Because if you have this garbage-looking waveform, it's this nice little shark tooth kind of like wave, kind of going, you get this nice even wave that tells you you're getting a good reading. If it's just all like, okay, you don't know what you're looking at. Okay, so if you can get one that's got one of those, if you're investing in that, that's what you're kind of looking for. How does it work? Well, it works by measuring how saturated the hemoglobin molecules are. Okay. Now notice I don't say how saturated they are with oxygen, because it can't tell you what it's saturated with, and I'll get into that here in a moment. Okay, but how full are those hemoglobin molecules? And it does it using an LED, usually a red LED, and essentially look at how much of it's getting absorbed. Okay? Usually placed on the finger, but there are some adhesive varieties that ERs tend to use that actually sometimes, especially when you get that really, really hypoxic patient or that patient that's in shock and the blood's getting shunted to the core, okay, I'm not going to get a really good reading on the hands. We used to slap them right on the forehead with those adhesive varieties because once again, I'm getting a central reading that way. But only the adhesive versions work, the finger ones don't fit on foreheads really well. Okay. Potential issues with the pulse oximeter. So remember I talked about hemoglobin needs to be saturated, but we don't know what it's saturated with. And we talk about carbon monoxide. Okay, carbon monoxide has a 300 times greater affinity for the hemoglobin molecule than oxygen. So, someone with carbon monoxide poisoning is going to saturate at 100%. Okay, this comes back to why you treat your patients, not your monitors. If you got a patient who looks bad, but you're getting numbers as they're saturated at 100%, you go, bullshit. Okay? Creates falsely high saturation readings. Okay, hypothermia. Okay, blood starts shifting away from the fingers. I don't have a whole lot of blood to read very well. Okay, so once again, I might get an abnormally low oxygen saturation if they're cold. Okay, the patient's moving. They're sitting there having a seizure. They're moving around doing something like that. Kind of makes it good for a bit of a blurry picture. Can't get a clean reading. Okay, nail polish. Okay, especially if it's red. Okay. It interferes with wavelengths, okay? So if you actually use a pulse oximeter, you should keep little packets of little acetone whites, stuff like that. Once again, quick little white, clean off the nail, put the thing on, okay? Just helps reduce the risk of it creating any problems. Even clear nail polish is even shown to create some problems, okay? Because it just interferes with us a little bit. But reds or any colored ones tend to be the more problematic of them, Fluorescent lighting. Okay, research is a little mixed about this one. This one's been going around and around for about 10, 15 years now of whether it is the case. The feeling is that, especially lighting like this, because it's fluorescent, it interferes with the red wavelength of light, and then at that point, you're not sure what the pulse oximeter is picking up. So for me personally, I just always throw, if I'm outside or doing that, I'll throw a towel over the hand. That way I know it's dark and I know that that thing is getting a nice clean reading. Okay, quick, simple, and easy way to adjust for it. Okay. So if we're going to give oxygen to a patient, how are we going to do that? Well, there's a couple of different ways that we can go about it. So pretty much we in the pre-hospital setting are going to be using oxygen cylinders, and they're usually named for their size, and they have letters that designate their size. The tank we have in the back over there, and we'll get to play around with, is a D cylinder. It's pretty much the workhorse of pre-hospital care, okay, for at least EMTs. If you work more in like hospitals and stuff like that, and even within our clinic, those tall, narrow ones that tend to be back on the back of wheelchairs and stuff like that, that's an E cylinder. All right, slightly larger in volume than a D, but not significantly more. But all of those have the similar characteristics of how we're going to use them. All the way up to the big, gigantic tanks that are about as big as me that are in the backs of ambulances that power the oxygen in the ambulance itself. The ones that we can buy as athletic trainers that are most accessible through a lot of our things like our Medcos and our sports health and stuff like that come in a couple different varieties. I'll talk about those in a second. But most oxygen cylinders are differentiated by the fact that they've got some green paint on what's called the shoulder of the tank. So it's pretty much the top to a little bit down, and that tells you that that's oxygen, as well as it usually has a label of oxygen USP on it. Okay. We need a regulator because that tank is under pressure. Okay, human beings can't breathe gas at 2,000 psi. Okay, that's just, we're not designed for that. Okay, so we need something that's going to set that pressure down into usable levels. Okay, they also have a little gauge on them, and they tell you how full the tank is. Okay, so it's like our gas tank. All right, the acceptable ranges: a full tank is 2,000 psi, and a tank that's ready for replacement is 200 psi. Okay, we never take, we're not supposed to take it down below 200 because it's what we call a safe residual pressure. We don't want to have too little pressure because then moisture can get in, corrodes the inside of the tank, and then you're not supposed to breathe in rust. Kind of bad for business. All right, and then ultimately what controls the dosage to our patient is called a flow meter. Okay, gives us essentially our dose of our oxygen. As athletic trainers, as I said, we have the ability to access tanks that are fixed rate and variable. Things from Medcos, sports health tend to be fixed rate, pretty much high or low. Okay, there's no guessing of like, oh, I'm going to adjust it here, I'm going to do this. It's kind of set value, like a stim unit on presets. Okay, I'm going to put it on pre-mod, and I'm just going to turn the thing on and walk away. Okay, as opposed to sitting in and going and fiddling with the individual components, which we didn't have with variable. The benefit with variable is now I can go and say, okay, this patient needs 3 liters or 4 liters as opposed to just 2. All right, this is a bigger patient, and to get high flow, I don't just need 12, I need 15, I need 18, I need 25. Hey, and I can go and do that. Coming back to tanks though, the D cylinder, if I run a D cylinder at 15 liters per minute, which is high flow, there's about 18 minutes of oxygen in that tank. Okay, so not a ton. Okay, E cylinders get a little bit different. I'd have to go run the math on that, and involves usually be passing out needing an abacus. But you know, not a big deal. But those are the 2 varieties that we'll see. Then ultimately we need the delivery device. How are we going to give that oxygen to the patient? Okay, I'm going to show you how you would put together an oxygen tank and how you actually handle one. They're going to show you how to set up an E cylinder on this one.
I'm Billy Jo with Medical Service Company. I'm a respiratory therapist. I'm here today to show you an oxygen tank. This is your backup tank. You would get this whenever you get set up on oxygen. You can see on the tank here you've got this little white label or kind of a cover. This shows you that the tank is full. You could have a white one, a blue one, a gray one. You want to take it off to actually use your tank. You can slide it right up over. If you can't get it off, you could always peel it off. And then underneath the white cover, you'll see on the tank you've got 3 holes on one side. And then if you turn the tank, you've got 1 hole on the other side. this up with your tank. You have to slide this on. And just slide it right over the top. You line up your 3 pegs and you twist this. And you keep twisting until it's locked tight.
Is this finger tight? You don't have to crank in and bend the thing into
You
place.
just have to hand tighten it. There's no need to tighten it with
Wow, Trent, you said
a
that too.
wrench or anything. And you can see on here the gauge. So you want to take this key. You've got these little holes there. They line up right on the top of the tank. You put them on there. You turn it about halfway. You can see the little needle popped up to the top. You'll never see the needle go further down. It'll always be at about 2,000. This tank is now considered open and on. To turn it, you turn this little end, and the oxygen will come on. You want to turn this number to the number that your doctors told you to use. So it should match your machine. Then on the bottom here, you're going to connect your tubing, which
I'm going to kind of end it there because they end up showing how to connect oxygen delivery devices. We'll talk about that here in a little bit as well. Questions, concerns about that? Okay, talk about some safety stuff. Okay, obviously we're not going to use oxygen around open flames, even though I have certainly seen my life flash before my eyes a few times. I've had patients on full-blown oxygen therapy smoking. I think actually the one that creeped me out the most was when I actually thought I saw something that was an urban myth. Someone smoking through their stoma, which I'm like going, I thought that was an urban myth. No. No, you're like going, you obviously weren't paying attention when they put the trach in, but okay. But obviously we're not going to use it around open flames. We never leave a tank unattended and unsecured, okay? A tank needs to be treated like a bomb, because it is, okay? If this tank is completely empty, so we don't have to worry about that one. But a real oxygen tank is under pressure. If that tank falls over and that thing breaks, that thing is going to be a missile, okay? I was actually trying to find it, but it was hard to find a copy I didn't have to pay for. For Mythbusters, they actually did one with a very large oxygen cylinder, what's called an M cylinder, but one that, once again, power about as big as me, went through about 7 cinder block walls. And that was when they busted the valve off the thing. So it's going to give you a bad time if you were to have it. If nothing else, too, tanks falling over can be uncomfortable. And also, like I said, unsecured, they can't fall over, they have to do it, or if you're going to lay them down, make sure they're in a bag, they're going to do something where they're safe. Okay? And we never try to use lubrication, especially petroleum-based, because they can actually spontaneously combust. So. All right, so delivery devices. Okay, we have basically 4 ways we can give oxygen to our patients. So we got the nasal cannula, okay, the resuscitation mask or the pocket mask, the non-rebreather, and our ever famous bag valve mask. Okay, so 4 ways we can give oxygen. Okay, the nasal cannula. Okay, can only use it on breathing patients. This does not work very well for patients that are sitting there just laying over. Okay. All right, and it gives oxygen through the nostrils. Okay, they're like 2 little prongs. They sit on the inside of the nose. Okay. Their slight breathing difficulties. Oh, I'm having this little short of breath. I have a little bit of chest pain. You know, they just need a little bit of help, a little bit of support. Okay. The old literature and all this stuff that said you set them to 1 to 6 liters per minute, and then at 6 liters per minute, the maximum amount you're delivering is about 44% oxygen, as opposed to 21% oxygen that we breathe just sitting here. Okay. Like I said, old data, but current some stuff in EMS, we're actually really evaluating the nasal cannula, and it's getting a little bit more hype. I don't entirely agree with the data that they're coming up with, because they're saying that actually now we can go as high as 15 liters on the sucker. I can tell you from personal experiences from messing around with this that anything over 6 liters per minute, it's like sticking your head out the car while driving down 88. Okay? It's not going to be particularly comfortable, but especially if it's humidified, it makes it a little bit more comfortable, and there's some logic behind what they're trying to do. I just don't think it's quite as feasible as some research is trying to make it out to be right now, but hey, this is just maybe me being like, back in my day we didn't do that. And I'm just being stubborn. Dumb enough. Okay? But the encouragement here is that non-rebreather masks can sometimes not give you enough volume to meet that patient's minute volume, so they don't feel like they're getting strangled and smothered, and so they'll feel air hungry and potentially not tolerate the mask. Or people with claustrophobia, like, I can't have something on my face, I can't have something on my face. Sometimes cranking up the nasal cannula and going a little bit harder on that one gives us a little bit more without giving us problems, okay? And they're actually suggesting that in really bad cases, we can actually combine it with a non-rebreather mask. I'll have a picture of that a little bit later. I remember just looking at this picture and I'm going like, that looks so stupid. But the research shows that it is effective, okay? The resuscitation mask, but it has to have an inlet, okay? So we've all seen our pocket masks, we popped open and they're all like, oh, they're solid, okay, whatever. Okay, some of them have a little port where you can actually connect an oxygen tube to, okay? These are great because then the idea here is we can use them with our non-breathing patients before we have a bag valve mask. And theoretically, we can use it as a simple mask where you can just put it over your mouth and you can breathe on it. The problem is, it's got a really low profile, and once again, that flow rate may not be high enough to give them enough volume so they don't feel starved. Okay? But theoretically, we can do this. I actually used this on my mother-in-law until we could get an actual non-rebreather for her mask at home before she ended up passing. I ended up using my pocket mask from scuba diving because all of ours have those for this reason. And they need a flow rate of at least 6 to 15 liters per minute, okay, to be able to provide even remotely enough volume. Okay, if we're using it at 6 liters per minute, we can deliver theoretically with a good seal about 55% oxygen. But when we're actually using it with our non-breathing patients, and we're using stuff like we're giving rescue breaths or giving breaths in CPR, we can actually give about 35% oxygen. Okay, because as we breathe out, we're breathing out a little bit of oxygen, but a whole lot of carbon dioxide. But by adding the oxygen here, we can once again get them to a little bit higher flow, dilutes out the carbon dioxide that we're giving them, okay, and makes it pretty effective and a nice slow option. The non-rebreather mask was the workhorse of oxygen therapy before the 2000s, okay? Now only used for those couple ones we talked about, carbon monoxide, bends, profoundly hypoxic patients, okay? Once again, patients gotta be breathing, otherwise it don't work so well. Okay, gotta have a flow rate of at least 10, but probably 12 to 15 is the most likely. Okay, once again, depending on how they're doing. There's a bag that hangs on, it's the reservoir. That bag shouldn't deplete more than 2/3 in volume per breath. If they go and breathe in, that bag is empty, and when they go and breathe in, you need to crank up the volume, okay? You shouldn't ever empty the bag, the reservoir bag, with a breath. Otherwise, you need to crank it up. Now, once again, old sources say, oh yeah, with the non-rebreather mask, you can have 95% or better. And then we actually looked at that and we go, no. The problem is that very rarely do we get a nice perfect seal on that mask. Furthermore, we learned back in the day, there used to be 2 valves on those things. So when you breathed in, you could only breathe in what was in the mask. But if your oxygen system failed, now you're just strangling the patient because now they can't breathe. So now there's an emergency valve. So one port is always open, which means now some air is spilling out. So like I said, even in a perfect world, you're going to get maybe 95%, but even then we're not getting the values we used to think. So we have Dr. Roman and Levitin. Dr. Levitin is an anesthesiologist who does a ton of research into oxygen therapies and oxygenation in the pre-hospital setting. So I mean, he's the Douglas Casa. Douglas Casa does all the stuff for heat illness with athletic trainers. So he's like the Douglas Casa of airway stuff for us. Kind of going back to this. So this is in that article in the Journal of Emergency Medical Services. This is that combination of the non-rebreather mask and the nasal cannula put together. Okay, as a way to make sure that they're doing that, because their logic is that the nasal cannula can sit and fill the sinuses with air, and that essentially creates its own separate reservoir as the patient breathes in to pull in higher concentrations of oxygen, is their logic. Especially if you get that patient who's getting kind of air hungry in that mask, you can kind of give them a little bit more. The problem is you have to be able, this only works if you have 2 oxygen sources, okay? And you pretty much have to have an ambulance to do that. So the feasibility for, once again, us in our settings may not be happening. And then there's the bag valve mask, okay? Every athletic trainer should have access to a bag valve mask, okay? And they're not expensive, and they've actually developed variants now that are called pocket BVMs, okay? The ones I was finding were ranging anywhere between 20 and 40 bucks, and they break down to essentially a little canister that's 2 inches tall by 5 inches wide. It can fit in every one of our 8 tea bags. Because if we have other people around us, and we can direct people to start doing CPR, and I can go and start working on a bag valve mask for my patient, that CPR quality is going to go up. Just from the standpoint of, I'm delivering at least ambient air, 21% oxygen to them, as opposed to whatever we're blowing into them. Okay? Just there. But once again, you can only use a bag valve mask when you have another person. Okay? It is actually best operated by 2 people. So even a third person in a situation now is getting into that. Because I need one person to work the seal, one person to work the bag, and then one person to be compressor or anything else. Okay? But we're going to give positive pressure ventilation to our non-breathing patients, and we can assist the breathing of the people who aren't breathing adequately. They're breathing 4 times a minute or 32 times a minute. Okay, we can help them out. Okay. So 2 ways to hold the mask in place. There's our classic EC method, okay, where the C is on top, the E is on the bottom, okay, and then you can actually double that. So you have like a 2-person setup, someone else is working the bag. I can do 2 C's, 2 E's, or I can push on the sides of the mask with my hands and I can do a jaw thrust, and that's actually the one that's been shown to actually create the best seal and the best control over the airway under current research. Okay. We want to operate the bag with our fingers, okay? Probably when you guys went through my class, I told you to use your hand or even against your body. We've actually really pulled away from that because we are actually finding we're over-ventilating our patients. We only need to be delivering about 5 to 7 milliliters of air per kilo of body weight, okay? So realistically now, we're only doing maybe half the bag now. The idea of, there's even talk of getting rid of what is an adult bag valve mask and just use kids and infants. Because a child size is actually really about the size of volume we should be getting to an adult. Okay, so 2-3 fingers, enough to get that bag to squeeze, and it's about halfway, and we're do that squeeze gently over 1 to 2 seconds. Okay, this is not a wham! Okay?
How'd that go work?
I got something for you on that one here in a second. Don't worry, I'm not going to take the humor away. Flow rates on the oxygen on this need to be set to 12 liters, at least 12 liters per minute. Okay? And depending on how big that sucker is, I've worked patients at 25 liters per minute. And the problem is, if you're only running on a D cylinder, you can't run at 25. Well, let me rephrase that. You can, for about 6 minutes. Not very long, okay? And once again, if we get a proper seal and we use a PEEP valve, and we'll talk about PEEP valves here in just a second, we can have really good oxygen saturations. PEEP valves are something else that's getting a lot of traction, getting a lot of big things in research right now. Before, when I went through school, a PEEP valve was this kind of novelty thing you had to worry about when you were dealing with like CPAPs and vents. Okay, but bag valve masks, because you were constantly taking the thing on and off, we were losing the seal all the time and it didn't matter. Okay, but now we realize, no, we really need to use these things all the time. So you and I, all of us right now, sitting here as we breathe, there's end pressure in our lungs that help keep the actual little sacs of our lungs inflated. Okay, it's called about 2 centimeters of water of pressure, just normal. Okay, once we go unconscious and all our airways open up, that seal is lost, all that pressure gets lost, and the lungs collapse. Okay, we want to try in our emergency situations maintain about 5 centimeters of water of pressure in that system with a PEEP valve. And then if we have that patient who's getting, we're doing everything we can, we've got an airway in them, and the sacs still aren't coming up and stuff like that, we need to start increasing our PEEP value. Okay, up to, once again, unfortunately, as research has been going through, there's about 3 different numbers that are floating around out there. Everyone agrees at least 15. Some people say 15, some say, a lot of people say up to 20. Right now, for us, I didn't want to pick a lane. 15 felt safe. All right, so sealing methods, and I'll show you that PEEP valve stuff here in a second. Okay, so as I said, our classic EC clamp method, pushing down, get that good pressure, and then locking it down with the rest of our fingers. Or the even better way now, as we've seen, is either side of the mask, pushing down, get that jaw thrust at the same time, gives us some really, really good control and opening in that airway. the effect of PEEP valves, okay, this guy's, you do this on some pig lungs, but you can actually really see the difference on what a PEEP valve can do here.
All right, in this quick video, I'm going to demonstrate VBM ventilation with and without a PEEP valve, show you what some of the benefits of using PEEP are on someone's airway. So, right now we're going to ventilate these lungs that hopefully don't look like yours with a regular VBM. You can see each time we bag, they completely deflate, right? All bagging piece of work. Now we add a PEEP valve set to a PEEP of 10. We start ventilating. We notice we end up with much different deflation at the end of those. And just to kind of really see what that PEEP is doing for us afterward, we remove, say we're taking someone off the vent to suction them, look what happens. We're going to have to recruit them all the way back up, back deflation. So again, ventilating without a PEEP valve, ventilating with a PEEP valve at 10. And then removing them from. Thank you for watching.
Alright. PEEP valves, some of them, when you look at your bag valve mask, some of them come with them already attached. Other ones you actually have to buy a separate attachment to go on them. PEEP valves generally only run about $10 to about $20 depending on your manufacturer. But if you actually go with like an Ambu type bag, they're actually made by Ambu, they have a cap that you can just unscrew and then the PEEP valve can go straight into it. Where the ones we're going to work with today, which are more of a Lordell type, you have to buy a separate 2 pieces on those. But once again, things to consider as you work up on. Okay? Especially in the new guidelines that are slated to come out in 2020, the American Heart Association kind of declined to take a position on impedance threshold devices, which are things that go onto the ventilatory circuit, and essentially it helps ensure that we get the right vacuum in the chest, once again improving that stroke volume, or the amount of blood per pump that we're going to get in CPR, and then we're trying to figure out the best way to combine PEEP and the thoracic impedance threshold devices. So once again, we're getting that, keeping those lungs as inflated as possible, but not creating too much pressure in the chest, so that not impacting that stroke volume of the heart. Okay, so that was the big thing I kind of wanted to walk away with that. But bag valve mask is something else I want you to feel comfortable with today, because it's something that is a very effective way for us to help our patients and really help the ventilation and oxygenation that we have for our patients. But it's a skill that breaks down. We all touch it once every 2 years when we do our professional rescuer, and we never touch it again for the most part. Every skill like that has a shelf life of about 6 months before it starts breaking down. Problem is, what's called self-efficacy, our ability to know when we can still that we can still do something, lags about 6 to 8 months behind that. So when you guys start going, man, I haven't done that in a while, I'm not sure if I can do that, your skill is already broken down about 6 months ahead of that. And then we changed our CPR cycles from 1 year to 2 years because it was cheaper and made better compliance for doing it. But the problem is by the time we're getting out to 2 years, the skills have completely deteriorated, and we're starting to really realize, you know what, I haven't done that in a while. We're at the year mark, we're at that point where we're already having a breakdown. So any chance you have to really work with bag valve mask and keep those skills up, it's always a good thing. Because it is something that, if done inappropriately, it can give us some problems, okay? So some common pitfalls of bag valve masks we have to avoid, okay? First things first, we gotta maintain an appropriate seal. Otherwise we don't get what we're looking for, okay? We don't get the concentrations, we don't get the pressures. We also get a little excited. We start bagging like we're gonna pump these people back to life, you know? Like a blood pressure thing. No, I can't. Because guess what? Speed is bad. Alright? We cannot go too fast. Okay? If we're not using an advanced airway, we're ventilating every 5 seconds for an adult and every 3 seconds for a child. If we have an advanced airway in place, we are ventilating every 8 seconds. 6 to 8 seconds. We're only ventilating 10 times a minute. Okay? So if you're a person working the bag, make sure you're keeping a count of when you're ventilating. And then the other thing we run the risk of, like I said, we can't just go, wha-bam, because we can have something kind of like this. And I found this very this very satisfying gif of someone overinflating a football. Okay? Because if I put too much tidal volume in, guess what? I will do that to one of your lungs. Okay? And then we're not helping.
Feels great.
Mm-hmm.
Okay, everyone. The last portion of this home study course is going to be a skill review. Those that went through the live event were able to kind of get hands-on experience using the various airway adjuncts and oxygen therapies. We're going to go through the skill sheets that are used by the National Registry of Emergency Medical Technicians to teach the skills, as well as how those skills are evaluated in practical exams. So we are going to kind of go through those so you can kind of have an appreciation for the necessary components. On the 20th slide of the PowerPoint, the video that is embedded I created during graduate school goes through the individual components of these so you can see those as well for the nasal airway, oral airways, and supraglottics. But for this next portion here, we're going to go through the individual steps via those skill sheets. As I said, I encourage you to kind of look through and watch that video on slide 20 in its entirety, and not where it kind of just jumps in where I had to cut. As you can see in this slide, here we have each of those skill sheets where you can find them on the National Registry of EMT's website, each individual PDF document. We're going to pivot to another screen here in just a moment where we can see each one of those individually. And we're going to make that pivot now. So this is the skill sheet for supraglottic airways. And every skill for the National Registry begins with taking appropriate body substance isolation using appropriate PPE. And that's at minimum gloves. As we deal with airways, we should consider things like eye protection and a mask, just because as we deal with secretions, the patient could vomit, these can come into our face, and obviously we don't want to have an exposure event. We always open the airway manually first, either head tilt, chin lift, jaw thrust, to get the tongue kind of off the back of the throat. And as we kind of said, we always kind of try to start with our simpler airways, our nasal airways, our oral airways. Get those in place and get those stable. When those aren't working well enough for us, or we're not seeing good chest rise, we're not getting changes in the pulse oximetry that we would want to be seeing, beginning to get resistance as we ventilate patients, we need to start considering more advanced airways. And we can start with the supraglottic airway. So this can be, like I said, your King LT, your combi tube, your eye gel. These are all supraglottic options. And so in the skill progression, we see that the bag valve mask needs to be starting to be utilized, so we're trying to see how that works and see if that's being effective for our patients. And we start with room air. If we can have it already set up to oxygen, great, but once again, it's one of those things that's not absolutely necessary at the onset of our use of the bag valve mask. But as soon as it's available, we should be using it, and remember that we need to really have a flow rate of at least 12 liters per minute on a bag valve mask, usually higher, up to 15, and especially if you have a really big patient, you're moving a lot of tidal volume per squeeze, we really need to have that flow rate set higher. But at a cost. If we're on a portable tank, like a D cylinder, running more than 15 liters per minute really gives us a very limited amount of time that we're going to be able to care for that patient. As we recall from the class, that a D cylinder that is running at about 15 liters per minute has about 18 minutes of oxygen in it. Anything more is going to burn up even faster. The other metric, too, whether it's a non-rebreather mask or a bag valve mask, we never want to see the reservoir bag that is attached to that device decrease its volume by more than 2/3 per ventilation. Okay, so in the bag valve mask, if I squeeze the bag and I see the reservoir almost completely empty, I need to increase my my flow rate for my oxygen. Vice versa, if it's the non-rebreather mask, as we'll talk about a little bit later, if the patient takes a breath and the reservoir bag almost completely collapses, we need to increase the flow rate. That bag should never deplete by more than 2/3. When we are not attached to an advanced airway, a bag valve mask needs to be done with one ventilation every 5 seconds, which gives us a ventilation rate every 5 to 6 seconds, which is ventilating every, it gives us a total of 10 to 20 ventilations per minute. That goes down when we have an advanced airway in place, and we ventilate every 6 seconds to 8 seconds. Okay. We never want to interrupt ventilations for more than 30 seconds. So anytime we're putting in an airway, anytime we're switching to something like a bag valve mask, we are trying to not interrupt our ventilations for more than 30 seconds. Okay. In this kind of grading scenario, you see that you're trying to do this stuff for about 30 seconds, they're not getting a benefit, and a supraglottic airway has been directed. So you always have to prepare the device, make sure the balloons are all set, we get your syringes pre-drawn to the air levels that you need. If you're using something like the King LT, it's on the lumen of the tube. If you are using something like a combi tube, that is a set value of air, and those are on the pilot balloons, so you can see exactly which one needs how much, be it the first tube or the second tube. And then something like the iGel has no inflation to it. It's a little bit more streamlined. We always want to lubricate any supraglottic airway. That is important, because without it, we are going to have trouble getting the airway in quickly, and also run the risk of creating some pretty nasty trauma to the patient's airway. We have to position the head properly, so it should be neutral. It shouldn't be in any lateral bending. It shouldn't be to rotation. We want to avoid, obviously, excessive flexion if the patient's supine. So we want them as neutral as possible. We use the method of a tongue jaw lift. This can be anything like a manual maneuver with a thing like a tongue blade to the maneuver that I jokingly refer to as the big mouth bass option, where you kind of stick your hand into the mouth, pinch the tongue down to the floor of the mouth with your thumb and forefinger, and hold that kind of stuff together and kind of lift up and away so that you can get that tube inward. We always put the device into its appropriate depth, whether that is, and that's going to be determined by the type of the airway, and usually it's some sort of marking at the level of the teeth. We secure the device in the patient, be it with balloon, be it with tape, what have you, based on that particular device. We need to attach our bag valve mask, ventilate, and we need to verify our placement by listening with a stethoscope, and we want to make sure we're having clear and equal breath sounds throughout the lungs. Okay, so we're not just ventilating one lung and not the other, that we're getting everything sounds clear. We also should try to verify placement with some other means that gets into carbon dioxide detection, if at all possible. These are some of those color-changing devices that kind of snap into the ventilatory circuit, all the way up to the most advanced types of assessment, which would be with capnography, or the measurement of carbon dioxide with a machine. Unfortunately, these devices tend to be very expensive and somewhat cost-prohibitive for us as athletic trainers. We adjust our ventilations after we've verified placement by either moving the tube around as needed. That's especially the case for like a King LT, because you place it to a certain depth and figure out if you're getting the chest rise you're looking for. You adjust your tubes if you need to, if you're using a dual-lumen system. We also ensure that that tube stays stable in the patient, and these can include taping the tube in place with things like tape, or using a type of device. It's usually called a Thomas device. It's a kind of a plastic mount. It's like a mouthpiece almost. You kind of wrap it around the patient, and you put the tube into it. It's got like a little screw grip hold point that essentially holds the tube in place and keeps it very, very stable. If you've watched medical shows and stuff like that, that's the usually that kind of blue little plastic mouthpiece you see the kind of the patient wearing, and then the tube comes out through the center of it. And as we said, we continue to make sure that when we as this kind of last little point here at the very bottom, that we ventilate the patient to the proper rate, which is going to be ventilating every 6 to 8 seconds. We're not completely pressing the bag or the bag valve mask. We're using about 2-3 fingers, about half the volume of the bag, enough to get that chest to rise and letting it fall. Nice easy squeeze over 1 to 2 seconds. We should see pulse oximetry improve if we are using pulse oximeters, and we are if we're using capnography, we should see good waveforms and good exchange. The numbers vary based on whether the patient's in cardiac arrest or if they have a pulse. Okay, let's now pivot into the bag valve mask skill sheet. There's a lot of overlap between the supraglottic airway and the bag valve mask skill sheet, simply because the two skills are very much interlinked. Just like the last one, we start with taking our PPE. We should be activating EMS if we haven't already done so, if we're having to pull out the bag valve mask. And certainly we're assessing our patient as we're trying to use that. Like I said, this is a little bit separate from the skill we just talked about. But airways open either through jaw thrust, head tilt, chin lift. We should have suction equipment ready. We should have suctioned the airway if it is needed, because otherwise we'll start pushing those secretions down into the lungs, and that's not necessarily good for the patient. Get that really good seal with the mask, which is very important, using either the EC clamp method or the two-handed jaw thrust maneuver that was mentioned earlier in the presentation. As we said, nice easy squeeze, get that chest to rise, ventilating every 5 seconds without an advanced airway in an adult, and every 6 to 8 seconds with a advanced airway. Continuing to kind of scroll through here, just kind of a few ideas of things that we really need to be avoiding, and as we said, the more than 30 seconds of interruption is not going to be good for this patient for positive neurological outcomes. For the last skill, the oxygen administration, the National Registry only has a skill sheet for the non-rebreather, but the steps are the same regardless of the delivery device. We always have our PPE. We need to get all of the stuff together that we would need: oxygen tank, flow meter, the delivery device, suction equipment. Have that all ready. We would utilize the oxygen tank as we would based off of the video earlier in the presentation. So we're taking the seal off, we're putting the flow meter on, we're making sure everything turns on properly, there's no leaks, it's full, or at least has enough to be able to take care of the patient at the level that we are anticipating. We attach, in this case, the non-rebreather to the port. We would put our thumb over the reservoir valve in the mask so we can see that bag fill up. But as you start seeing it fill, you can take your thumb off. Otherwise, if you keep your thumb on it, you can just pop the bag, and then it's not a very useful airway or delivery device. We would still put the airway on the patient, or I'm sorry, the delivery device on the patient. We want to make sure we get a good seal, and the way we kind of do that is kind of quickly, if we kind of pivot back into the PowerPoint. I'm going to get a little drawing tool out here. So we want to make sure that stuff like the edge of the mask here doesn't have any gaps. It fits snugly. We want to, ways we can kind of go about that and make sure that that works as proper sizing. So we're actually not trying to put an adult mask on a child, and vice versa. We want to pull the straps appropriately tight Okay, so you see here, that should pull snug, but obviously we shouldn't be crushing their face. They should still be able to kind of speak and move around. There's the nose piece here. We want to certainly mold that so that it gets a nice tight fit over the nose, so that kind of helps create that seal. And coming back to the reservoir bag down here, like we said, this bag should never deflate by more than 2/3 with each breath. If it is doing that, we need to increase our flow rate. So we can be starting at something like 12, but okay, that's not enough. I can go up to 15, and you can even theoretically go higher. But as mentioned earlier in the skill section, the faster we run the tank, the faster we deplete it. And D cylinders give us best case scenario of about 18 minutes at 12 to 15 liters, and we're going to go through that faster and faster. Even in this picture here, you can see with the patient having a nasal cannula in place, if you were to use just that device without the non-rebreather mask, you see these little prongs here. They have a curve to them. You want the curve to go into the nose and towards the patient. You put it then over the patient's ears, and then there's usually a little plastic piece that's going to be around here that you just kind of slide into place, kind of almost like a bolo tie. That keeps it nice and snug, keeps it from falling off the patient as they walk around, move, and talk. You can combine the two, as you see in this picture, and you would just combine the two actions of putting on, you would put the nasal cannula on first, and then you would apply the non-rebreather mask. Coming back to the skill sheet here, we talk about that snug fit. We want to have an appropriate flow rate. We want to see pulse oximetry improve. If we're using capnography, we want to see that improve as well. So that we have a nice clean waveform, that we're in appropriate ranges for both pulse oximetry and our carbon dioxide levels. We should see our patient respond. And with all of this, whether we're placing a supraglottic airway, whether we're using a bag valve mask, or if we're using things like any oxygen therapy or airway adjuncts, we're documenting this. What time is this stuff going in? What are we using? What was the patient's response to it? How often are we checking it? As you know, especially if these patients are unstable, we should be reassessing them at least every 5 minutes. We want to make sure the interventions are still doing what we want them to do. With an airway adjunct, is it... Sorry, I had a little technical issue there. But kind of finishing that thought, with our airway adjuncts, we need to be really verifying that where we put them, are they still at the teeth, or at a particular depth marker? Are our pilot balloons still firm if we have those? Verifying still that we're have placement through listening, auscultation of the chest, and we should hear clear and equal breath sounds bilaterally. We shouldn't hear breath sounds over the epigastrum, over the stomach. And just, as we said, just continue to document that. Practicing these skills are important. These skills do break down over time. If we are doing per diem work, certainly the ability to practice these things at the beginning of the season, working with a group, certainly aren't available. But if we are in a school or in a university setting where there's going to be a larger kind of staff, this stuff should be practiced. Each season would be ideal, or at least once a year. For those of us who don't have that kind of work setting, potentially spending some time with an area fire department, seeing if there's an ability to go and do, hey, is there a night or a day that you guys are going to be doing these skills? Can I come in and join you? It certainly keeps your skills up to date, but also affords us that professional opportunity to grow relationships in the community. They can see what we're able to do and what we're capable of, and respect us as being able to do these things. And that certainly elevates our profession and our own ability to benefit our patients for positive outcomes. I hope this learning event was useful and helpful. Certainly, I encourage you to download the PowerPoint if you haven't already. Look through those slides, kind of gives you that kind of clearer detail if you weren't able to see it through the video. Like I said, once again, thank you for your time, and please do take the quiz to get your credit for your CEUs. Thank you.